So good afternoon, everyone. In this session, I'm going to talk about nerve blocks for headache, and I will show you video demonstrations. Afterward, if we have time, we can make discussions, interactive discussions together, okay? And we also have a patient. I will show you how we do these interventions. As you know, sometimes it's really difficult to treat patients for chronic headache. And at that time, we use these interventional therapies, as well as when we plan to do a bridge therapy for the fast efficacy, you can use these interventions as well. These methods are really safe and feasible in pregnancy and the lactation period as well. And in patients who have side effects because of the drugs or who have comorbid diseases that they cannot use the preventive medications, you can do these nerve blocks in those patients. So the mechanism, they are based on blocking the sensorial fibers because they are very low concentrations. For the nerve blocks, we use a very low concentrations of local anesthetics. These local anesthetic binds to the sodium channels through the C fibers, sparing the A fibers. They just make nerve blocks for the sensorial fibers, so they don't have any motor complications. But be careful for the low concentrations because their diffusion is related to the myelin thickness. If you give the low concentration, they just tend to diffuse much better to the C fibers, sparing to the A fibers. But the question is, how a long-term efficacy result with a local anesthetic lasting mostly 12 hours? So the physiological answer for this question might be the breaking the cycle of the chronic pain and indirectly winding down the central sensitization. It's just about on discussion, the efficacy of these interventions. So we use nerve blocks in many types of headaches, as you can see here. Which one is the pointer? So as you can see, I cannot use it. Is this the... Oh, okay. So as you can see here, trigeminal neuralgia, cervicogenic headaches, but mainly in migraine and cluster headache patients, we use these interventions. So which local anesthetic can be used? Any of them, but considering the side effects, I prefer or I suggest you to use lidocaine or bupivacaine, either alone or with the combination. The most commonly used one is the lidocaine with a shorter onset of action, and it's more safe in pregnancy. Don't forget, it's also important. Lidocaine is safer in pregnancy, but you can also use the bupivacaine. For the lidocaine, we have 2, 4, and 10% medications available. So for the steroid, it's all discussing. Some suggest to use, some doesn't suggest, but in our practice, we generally use steroids because it affects a longer efficacy. So when you use steroid, the efficacy is much more longer. So what about epinephrine? When you use lidocaine, definitely you should combine it with epinephrine, because epinephrine lower blood flow around the nerve, so minimize the systemic side effects of the local anesthetics. It also prolongs the duration of the nerve block effect. So where we use these blocks, so you see the diagram here for migraine, and this is the place where we use these blocks. In episodic migraine, you can even use them in the attack management. And in chronic migraine, when you have a lack of efficacy for the preventive medication, you can use here before the modulations or botulinum toxin injections. For the neuralgias, you see there is a lack of efficacy for the medical management. You should do it here before you try the more invasive interventional methods. So they are semi-invasive and very safe, so you should try them first. Is there any proof for these interventions? There is no guideline, there is no consensus, but we have many papers suggesting the efficacy of these methods. So we have proof for that, but we need a further larger studies on these. So before the procedure, you have to inform your patient about the procedure, about the side effects, and the consent form should be obtained from the patients. Be careful for the contraindications, and if your patient is using antithrombotic drug, you should stop it 5 to 7 days prior to the procedure. This is Turkey. So we will start with the sphenopalatine ganglion block. The sphenopalatine ganglion is the only ganglion having access to the outside environment through the nasal mucosa. So it is the largest and most superior ganglion of sensorial, parasympathetic, and sympathetic nervous system. So superior salivatory nucleus receives stimulation from the trigeminal nerve and activates the sphenopalatine ganglion SPG. The activation of SPG results in the release of neuropeptides causing a vasoneurogenic inflammation and triggering headache. So this is the relation for SPG and the headache. So there are some procedures we can reach SPG, intraoral, zygomatic, or intranasal. So when you talk about intraoral, it is the most painful and most difficult method to use. When the needle passes through, the canal contains artery and the nerve tract, so makes it painful, and some side effects, complications as well. So we generally don't use intraoral method. So zygomatic way, either supra or infra, you need a fluoroscopy for guidance. So that means it has a radiation risk, and you cannot do it, it's not feasible to do it in the outpatient clinic. You need a room, and it has a radiation risk. But now there is a new technique for the ultrasound-guided SPG through the zygomatic way. It's not easy to find it on these bones because it's really difficult, but in the experienced hands, it seems to be promising. for us, but we don't do it right now. For intranasal procedure, it's the most commonly used and most safe procedure. In our clinic, also we use this method with different modification, as you can see here. So the first one is the traditional, old traditional method with the cotton swab method. Oops, sorry, I'm so sorry. Yeah, they should be open automatically, but. So this is the cotton swab. You soaked it into the 10% of lidocaine. When doing SPG, we use 10% of lidocaine. You soak the cotton swab into the 10% of lidocaine and then insert the cotton swab into both nares, about 6 to 7 centimeters deep, and the aim is to reach the posterior of the middle turbinate where the SPG is located. So as you can see here, you soaked it into the lidocaine, 10% lidocaine, and you directly insert it into the nares 6 to 7 centimeters deep to the posterior of the middle turbinate, and you should wait about 10 minutes. During this procedure, we also inject about 0.75 cc of 10% lidocaine along to the cotton swab, or as you can see here, we put the cotton swab inside and then we inject 0.75 cc of 10% lidocaine again. We wait 10 minutes. Why? Because SPG is covered with a nasal mucosa, so when you inject the local anesthetic, it will diffuse through the nasal mucosa and reach to the SPG area. So you should wait at least 10 minutes for both application, for both sides. Now there is a new paper suggesting a modified cotton swab. What they mean is to curve the cotton swab about 45 degrees curve for a better placement. So they we insert the cotton swab to the inferior meatus and then change the direction to the posterior side and come to the posterior of the middle turbinate where SPG is there. So the technique is the same. You again use the 10% of lidocaine and wait about 10 minutes, but just the placement is different, so they suggest that it's more efficacy. So we also use this modified cotton swab method as well. Right now, there are some low-risk devices that you can make to SPG blocks. As you can see here, Siphenocat, TX360, and the Allevio devices are available. So depending on what you have in your country, you can use any of them. So we have Allevio in Turkey. So the device has a blue color flexible sheet, and then as you see here, directional arrow, white color directional arrow. So you insert the device anterior passage of the nose until you feel the bone. After you feel the bone, you change the direct to the posterior of the middle turbinate and you inject about 1 cc of local anesthetic there. As you can see here, this is a device, it's a flexible sheet. So there is a direction arrow here. So you put it the anterior nasal passage, just the very anterior side, and go inside until you feel the bone. You inject 1 cc of the lidocaine, again 10%, and wait about 10 minutes for the diffusion. So this is the new local devices. But as you can see, all intranasal methods are the blind methods. We are not sure if we really reach the SPG or not. So for us, the best method is to use a nasal endoscope, which is a very, effective. You can visualize the SPG and you can make a more efficacy treatment. So before the procedure, we spray lidocaine and decongestant to the nares, to open the nares and make the intervention easier. And as you see here, the gauze, all the gauze are soaked into the 10% of lidocaine, and then the patient sits supine, the head is slightly elevated, and our target is to reach the posterior middle turbinate. You can see here a very vascular area. Just above this vascular area, it's the SPG site. It's very easy to find, and it's really easy to use this procedure in the outpatient clinic. Even the patient has a septal deviation, you can do it easily. Or there is another, I'm sorry, you put the gauze inside, as you can see here, and the patient lies a little bit more, and you wait about 10 minutes. After 10 minutes, you take the gauzes out. So the same technique, but you see the exact place of the SPG, and you make the local anesthetic directly. Or you can even inject your local anesthetic onto the SPG. What I mean is, you make the injection, as you can see here, you make the injection, you pass through the nasal mucosa about 2 to 3 millimeters away, and you directly inject your local anesthetic onto the SPG. But with this method, you should use 2% lidocaine, not 10%. A low concentration of lidocaine you should use. It has a small percentage of bleeding side effect, but it's really controllable, and it's a really safe application as well. Now, we routinely do this procedure in our clinic. So after the SPG procedure, you should follow the patient about 30 minutes for any side effects. And we generally advise patients not to take shower for 24 hours. And as you can see, while giving the local anesthetic, they swallow the local anesthetic and they feel some numbness on the throat. So we advise patients not to eat or drink until this numbness passes away. Or again, these local anesthetic may lower the blood pressure, so you should check the blood pressure before and after the procedure, and the patient should be followed, again I say, 30 minutes for any side effects. So this is the SPG. Now come to the greater occipital nerve block. You know, it is the main branch of the second cervical root, and for the location, you have two parts. We have a distal location and the proximal location. For distal location, you have a line from the occipitalis protuberancia to the mastoid process, and it is the 1/3 of the medial side of this line. It's a distal part of the nerve. For the proximal part, from the occipitalis protuberancia, you measure about 3 centimeters down and 1.5 centimeters laterally, so you can find the proximal part of the nerve. But you can easily palpate the occipital artery. This nerve is just medial to the occipital artery, so you can make the injections. Be careful, before making the injection, you have to check for the blood. You may go into the artery, unfortunately, so you have to be careful. Where we use this intervention, mainly in migraine patients and cluster headache patients, also occipital neuralgia and many others. So before you do the intervention to the greater occipital nerve, it's better to check the sensitivity of the nerve. When you check the sensitivity, if the patient has a sensitivity or tenderness, this means that your application will be useful. You will have an efficacy on this. So we advise you to check the tenderness before you make the block. Now this is how we do the block. As you see, we measure. I do it in the proximal side, so 3 centimeters down to the occipital protuberancia and 1.5 centimeters laterally, and we found the place. We press with the finger and check for the tenderness again, and we do the injections. So in these injections, what we use for medication, we use lidocaine, 1 cc of lidocaine, combining with 1 cc of bupivacaine. You can use either one of them, but we generally combine them, and also steroid, 40 or 80 milligram steroid we use in these injections. And for migraine, we generally do these bilaterally, not unilateral, bilaterally. So after the injection, again, you have to follow the patients for some time for any side effect. But the best way is to do it with the ultrasound guided machine. About for 4 years, we do that with the ultrasound guided machine. It's more feasible, it's more safe. I mean, you can measure the area and you can see from the ultrasound the artery, and you just inject, make your injection just medial to the artery, as you see here. Now we will see the artery. It's our clinic. We do twice a week intervention in our clinic. As you see here, there's artery, just medial side of the artery, you can make the injection. So it's more and more safe. It's very easy to find the area as well. So for the supraorbital and supratrochlear nerve blocks, we generally combine these interventions with the greater occipital nerve blocks. Or if patient has any atypical face pain, you can do these blocks as well. So the supratrochlear nerve is just above the eyebrow in the medial border here, and supraorbital nerve is just 1 centimeter lateral to the supratrochlear nerve. When you make the press, sometimes you can feel the tenderness, you can hear the tenderness from the patient. So you can, as I said, you can combine them with the greater occipital nerve, and we generally inject 0.75 cc in each point. So this is how we do the supraorbital nerve block. I advise you to do it just up to the eyebrow, not down, just up to the eyebrow. So we clean the area before. And we identify the exact place. So before we aspirate as well, and we inject 0.75 cc. For the face intervention, we don't use steroid, just local anesthetics, don't forget. So this is the supraorbital. And infraorbital nerve blocks, you can use this intervention in trigeminal neuralgia, mainly in the maxillary branch of the trigeminal neuralgia or any infraorbital neuralgia. So where you can use, I do it intraorally, so the place is just lateral from the third canine, first, second, and third canine. I do it laterally from the third canine. You can also feel the glow here, I mean the infraorbital area here, and you can directly inject your local anesthetic, about 0.75 cc to 1 cc, but we generally use 0.75 cc. Here how we do it, so we identify the infraorbital glow, as you can see. So from the third canine, we go directly into it and we inject about 0.75 cc of local anesthetic. So as you can see, they are really very easy methods, and you can do it everywhere, outpatient clinic, and they are cheap methods. You don't need anything to do these methods. This is also Trabzon, where I born in Turkey. I advise you to visit there. So trigger point injections, they are the hallmark of myofascial pain, and we generally see trigger points in any kind of headache patients. So the local pain is due to ischemia of the prolonged muscle contraction and the accumulation of the chemicals. So our aim is to make the disruption of pain by mechanical effect of the needle and chemical effect of the agent injected. When you inject the trigger point, you generally feel a muscle spasm that we call it a twitch response. If you feel this muscle spasm, this means that it will be it will be effective. So how we do it is we identify the trigger point by pressing the muscles with the fingers. You can also use the algometry, but we generally use fingers. So you check for trapezius, sternocleidomastoid muscle, semispinalis capitis, planius capitis, and temporalis muscles. In chronic migraine or tension-type headache, they generally have trigger points in these muscles. So in routine, we check for these muscles. And before the injection, patient should be seated or in a recumbent position because there might be a vagal reaction, so he should be seated. So before the procedure, we clean the area, and you may use some local anesthetic for the comfort of the patient as well. So we identify the trigger point, we stabilize it with 2 fingers, and inject just 1 centimeter away from the trigger point, and then slowly go inside the trigger point with a 30-degree of angle, and aspire the injection, and then inject, then withdraw, redirect, and do many different injections in the different positions to surrounding the trigger point. You do about total 2 milliliters for the surrounding of 1 trigger point. So you do in every directions of the trigger point. You should be careful for the side effects of these interventional methods. You don't see it. I mean, they are rare, but you should be careful about the allergy of the local anesthetics, or for the hypotension, or for the pregnancy. In the first, I told you that you can use them in the pregnancy, but be careful. We don't use them in the first trimester. It should be after 15 weeks of the pregnancy. Also, vasovagal reaction or syncopal reaction, you should be careful. And as I told you, antithrombotic medication, you should stop 5 to 7 days before the procedure. So these methods, I mean, there is no definite studies examining the useful of these methods, but reports suggest that this area deserves further attention, acquiring more evidence-based data. It can be used for the preventive medication, it can be for the bridge therapy, so they are generally effective. They are easy and applicable in headache outpatient departments, but we still need more blinded and placebo-controlled studies for, in this field. Now, this is my last slide, but I want to tell you our new book that's in press for the Springer is pressing this. It's about peripheral intervention management in headache, and it has too many videos inside. I advise you to check it, but it's in press right now. Thank you.
Thanks for Dr. Durreya. And any question?
We have a patient, and after the speech, we do the practical there as well. You can also ask questions if you want later.
Thank you very much for your nice presentation. I think it's a continuation of the presentation we had in Marrakesh. My question, because you said that you can also inject lidocaine with the corticosteroids and epinephrine. In practice, do you use the 3 substances?
Yeah, in practical, I mean, not for the face, but for the occipital nerve, we use it 1 cc lidocaine with epinephrine. I have it here. I mean, we have a drug, combined drug, and 1 cc bupivacaine, and about 4 to 8 milligrams steroid together, all together, for the occipital nerve blocks.
What kind of steroids do you use? Solimedrol or
Sorry?
methylprednisolone? Or what?
Methylprednisolone we use, but you can also use.
Yeah. And there is no side effects in this prophylaxis? Just maybe some bleeding or some, no, but like for the face?
You have to press a bit more, about 2 minutes after the injection, because there might be a hematome formation or bleeding, so you have to press a bit, about 2 minutes after the injection. Thank you. Thank you for this.
Excuse me.
Thank you for the lecture. I want to ask about the interval between this intervention.
If you need to repeat the interventions, if you don't use steroid, I mean just local anesthetic, you can repeat them between 2 weeks to 4 weeks. In between 2 weeks to 4 weeks you can. What we do is we repeat them in 4 weeks. But if you use steroid, you should wait a bit more, about 3 months intervals you can use for side effects.
Yeah, excuse me.
You didn't tell us what's your nerve block, which type in different types of headache. You told us all
Sorry, again?
in the different types of headaches, migraine, tension headache, neuralgias, whatever. Which nerve block you use?
There is a table for this. But for migraine, we generally use occipital nerve block, combining it with supraorbital or supratrochlear. Or also in migraine, we now start to do the SPG blocks. For about 6 to 7 months, we start to do SPG blocks. If the patient have refractory to the occipital nerve block, so we try SPG in migraine. For trigeminal neuralgia, we directly do the infraorbital or mental, I didn't mention for the mental, and SPG together. For cluster, you know, SPG is the best technique for cluster headache. So we start with the SPG in cluster headache. So all change.
Thank you. For the trigger point injections, you feel the tenderness on the muscle and you insert your needles there. So we block the nerves or we just relax the muscles with a...
We just, I mean, the needle make a chemical effect for the disruption of the trigger point, and the medicine you give make another effect to disruption. I mean, the aim is to disrupt all the spasm. Yeah.
The effects in fibromyalgia, can I use it? And how many points can I inject in the one setting?
I don't have fibromyalgia patients, so I don't know it. I mean,
It's like my facial pain syndrome, I guess the same etiology. How many points can I inject? If I have 8 or 10 tender points, how many?
just maximum 3 or 4.
3 or 4.
Yeah.
How many cc? How many cc in each trigger point?
Because the local anesthetic you give,
Yeah.
it's, I mean, limited. You know, you cannot give much
How
more.
many cc in every point? 2
For
cc?
each point, I generally use 2 cc.
2 cc.
And I do generally maximum
But
4
here
points.
have
For supraorbital and supratrochlear, I do 0.75
0.7
cc.
in greater occipital,
And for
3.
the occipital, it's 1 cc lidocaine, 1 cc bupivacaine.
Okay, thank you.
Any other question?
Thank you for your nice presentation. I have just few questions. Like, for example, after injecting these local injections, how to know whether there is effective response to your treatment? One. The second question is...
The effective result starts immediately.
Yeah, it's just because it is local, fast acting. We don't know whether it is a long period of stay or whether there is recurrence of the pain. How do you know whether it is long action? So on long term, because the pain may continue after the injection has gone away. So probably we don't know whether there is recurrence. And the second question is...
You are definitely right. You are definitely right. It depends on the patient. Sometimes it has a sudden, immediate effect, but the pain starts 12 hours later. But generally what we check is we call patient 14 days later and check for the efficacy, and if they need another injection, we repeat the injection if we don't use the steroid.
Because I ask you this question because patient with trigeminal neuralgia, for example, where I usually use for infraorbital injections for V1 or V2 and V3 trigeminal neuralgia because they come with recurrence. So are you do you combine with other analgesics like carbamazepine on top of the
We don't change any drug during these procedures. In trigeminal neuralgia, what we do is we do infraorbital mental and combine with the SPG block and repeat the blocks 3 times every 14 days. I mean, 14 days after, and 14 days after. We repeat the blocks 3 times in patients. It's routine in our clinic because after the first injection, generally it's not so effective, but after the second, the efficacy starts, as we see. But there is no consensus, as I said. I mean, every center, have their own experience. So this is our experience.
What if you combine with PO medications?
They already getting their medications. I mean, we don't increase or decrease the medication. We just add these interventions to the treatment. So otherwise, you cannot understand if it is the medication you increase has the efficacy or the intervention. So it's difficult to say this.
Okay.
Thank you very much for such a nice and extensive
Thank you.
presentation. I'd like to just tell about our experiences. Maybe it would be helpful for some of the questions. One of the main applications that we use is for medication overuse headache. When we see patients with migraine and medication overuse, when we stop all the medications, people need something else. And in that case,
in the bridge therapy.
As a bridge therapy, when you stop the analgesics, they need this. In that case, we most of the time do not use any prednisolone, but twice a week for the first 2 weeks. We do the injections with the greater occipital nerve or sphenopalatine. It helps, and when the gone blockage is effective, patient usually describes as if the numbness, like memorized, half of the head is memorized. It's very important to ask if it is like this, they feeling like this, that means it's effective. And he or she could be pain-free for 2 days at least. So it's important on one side, and on the other side, during the cluster headaches, sphenopalatine is the best, and sometimes even the patient does not have any attack. You can use sphenopalatine blockade as a preventive at the beginning of the drugs. Some of our patients do not want to use any prednisolone. We gave the verapamil, but sometimes you cannot increase the dosage of verapamil. In that case, we use sphenopalatine blockages in between for the first 2 or 3 weeks. Last comment is about the fibromyalgia. If we see the fibromyalgia that you ask, mainly the fibromyalgia is the associated comorbid disorder with migraine, particularly the chronic migraine. If they have also the headache, even the sphenopalatine ganglion blockade helps to reduce their pain on the other sides of the body. Instead of 2 milliliters, only 1 milliliter injection to the important trigger points you can add, and also one, not only to 2, like many places. Which
more places, but low doses.
Low milliliter. Okay, thank you.
Thank
So
you. Excuse me for time, please. And thank you, Dr. Duria. And now with Dr. Ahmed Al-Sadiq. He will present the ultrasound guided cervical root.
Hello, I will, this session, I will cover one of the relatively new fields in neurology, the ultrasound-guided intervention for cervical radiculopathies, which is one of the causes of secondary headache. I will talk in brief. Cervical radicular pain manifests as pain in the neck shooting down the upper extremity caused by irritation of the spinal nerve at its exit from neural foramen. Prevalence about 1 per 1,000 individuals. Selective nerve root injection or block allow for further pain control and reduction of the use of inflammatory mediators in patients with persistent radiculopathy. Ultrasound allow us for visualization of soft tissue, nerves, vessels, thus potentially improving precision and safety. Our aim is 2Ds, direct infusion of the drug, steroids and local anesthesia, and mechanical hydrodissection. Advantages of ultrasound-guided cervical root injection. First is efficacy, provide real-time image of needle advancement motion to the target site. Recent studies show that ultrasound-guided injection has the same efficacy as the classical method, which is fluoroscopy-guided technique. Ultrasound allow good visualization of the soft tissue, such as abnormal, which further enable accurate needle placement and avoid the risk of error injections. The second is the safety. The ultrasound guidance does not expose patients or medical personnel to radiation such as fluoroscopy. Guided injury to important structures like radicular vessels, vertebral artery, and spinal cord. The technique of ultrasound-guided injection depends on the use of ultrasound system with high resolution and musculoskeletal software, which with high frequency probe can range between 9 and 22 megahertz. We use the mode which is called B mode, brightness mode, for the anatomy, for sonoanatomy. And we use two techniques for needle advancement, in plane technique and out plane techniques, and I will discuss in the next slide two techniques. And we use also color mode to avoid injury to vascular structures. This is the two techniques of needle advancement in ultrasound. The first is the in-plane technique. This is in-plane technique. Here the needle is perpendicular to ultrasound beam, which is parallel to the linear probe, and we can see all the shaft of the needle. And the out plane technique, there is more wide angle between the needle and the ultrasound beam, and we can see just the tip of the needle like this, but in plane technique we can see all the shaft of the needle. We try to use in plane technique in cervical root injection to see the whole shaft of the needle. Our procedure, we inject cervical roots from the posterior to anterior approach. We shift the head of the patient to the opposite side. We start in the supraclavicular fossa and use the linear probe like this, sterilization of the skin here, and insert the needle trying to approach through scalenus medius, scalenus anterior to reach cervical roots, and we will see in the ultrasound. This is the in-plane technique. We try to make the needle parallel to the linear probe to see all the needle shaft. This is the anatomy. This is sternocleidomastoid, scalenus anterior, scalenus medius, and the intrascalenus groove. And we approach through the needle, through scalenus medius to the intrascaline groove to approach the tubercular fossa between the anterior and posterior tubercle, which is the nerve root is located. This is anterior, the common carotid artery, common carotid and internal jugular vein with vagus nerve, and we notice that's away from our procedure or our path. And phrenic nerve is here between sternocleidomastoid and scalenus anterior, so we better avoid the anterior approach to avoid injury to the phrenic nerve. This is the same image in the ultrasound. This is anterior and this is posterior. This muscular structure is the sternocleidomastoid. This is the common carotid artery. And this is the shadow of the transverse process of cervical vertebrae, C5. And this hypoechoic structure is the C5 root. This is scalenus anterior, this is scalenus medius, and the intrascaline groove. We can see the C5 between the two, it's called the two-humped Campbell sign. This is another level, the level of C7, but now this is anterior and this is posterior. This is scalenus anterior muscle, scalenus medius, and the intrascaline groove contains the roots, C5, C6, and C7. If we use power Doppler or color mode here, we can differentiate between C7 and vertebral artery, vertebral veins to avoid injury. Because in B mode, the echogenicity is the same between C7 and vertebral artery. But if we use Doppler mode, we can differentiate between a root and the artery. And I will, this is video, live video for localization of the cervical roots in ultrasound. This is anterior and this is posterior. This is common carotid artery, internal jugular vein, sternocleidomastoid, scalenus anterior, scalenus medius, and this is the intrascaline groove contain the C6 root. This is the anterior tubercle and posterior tubercle. We can differentiate between C5 and C6 by that anterior tubercle in C6 is taller than posterior tubercle. This is different from other roots, the C5, C4, the anterior and posterior tubercle is equal. C7 has rudimentary anterior tubercle, so we can see just the posterior tubercle of transverse process of C7. Let me start the video. This is the C6 root. We can notice that anterior tubercle is taller than posterior tubercle. This is C5, anterior tubercle and posterior tubercle equal, and this is the root. This is C5 root. And this is the rim of the transverse process. Again, to C6. This is C6. And posterior tubercle and anterior tubercle. Again, this is C5. We are moving by the probe down and upward. This is C5. And again, C5. Then, this is a video demonstrating the injection. Now we use the color mode to identify and locate vessels to avoid it during injection. We have here, we can see the needle advanced toward C6 root. This is the tip of needle and the shaft like this, approaching C6 root. And this is the color artifact of the injectant fluid, which is steroids and local anesthetic. This is during the injection, we can see the fluid here. This is the vessels, radicular vessel, common carotid artery. So we can avoid, and this makes safety, we can avoid vessels during injection. This is the injectant fluid now around the root. This another video for the same patient. Injection of the C5 root. We can see the shaft of the needle trying to approach C5 here, and this is the color of the vessels. We try to approach the root, and you will see now the color artifact of the injection. This is the shadow of the needle, and this is the needle. We will inject now around the root. This is the color artifact of the drugs around the root, which means successful injection. Thanks for your attention.
Thanks, Dr. Ahmed. And now, any question for Doctor? طب أنا بيحضرني بس السؤال يا دكتور أحمد. دكتور أحمد.
أي فندم.
معاك أهو. لا السايد إفكت بالنسبة للمانوفر ده.
نعم يا فندم.
السايد إفكت.
الحقيقة في فندم ستاديز كتير على اتعملت من 2000 يمكن و13 لغاية النهارده على السيفتي اوف ultrasound جايدد انجكشن فيرسس حتى الستاندرد ميثود اللي هو الفلوروسكوبي جايدد، والحقيقه كل الستاديز معظم الريزلتس بتاعتها بتقول ان مفيش ولا بورتد انجري. دي اكتر حاجه كانت يعني بيدوروا عليها انجري لا لفاسكولار ستراكشر لنيرفس ستراكشر، لان زي ما حضرتك شفت انه احنا شايفين كل الفيلد قدامنا، الفيسلز واضحه جدا، وبالتالي وانس ان انا قدرت اعمل ايدنتيفيكيشن للنيدل واخد الابروتش اللي هو بوستيريور تو انتيريور، لان احنا بنافويد الانتيريور ده عشان الفرينك نيرف، فما فيش ريبورتد كومبليكيشنز من البروسيدور يعني.
طب برضو بيحضرني سؤال اخر برضو.
اتفضل.
حضرتك قلت ان النسبه 1 في 1000.
من
متهيألي اكتر من كده يا دكتور احمد.
يعني والله حضرتك هو كانت ستاديز يعني هي كانت الحقيقه البريفالنس دي جايه من ستادي اتعملت يمكن في 2017 على يمكن الاستادي كانت ما اتعملتش على عيانين كتير، بس حوالي 320 عيان او حاجه زي كده، فممكن طبعا البريفالنس يبقى اكتر من كده. فلكن انا مع حضرتك انه ممكن يكون البريفالنس اكتر من كده فعلا بصفه.
Any question؟ طب في برزنتيشن ثالث؟ دكتور احمد عبد البر، شرف.